Hello again, everybody. This is Rusty, aka William Robinson, aka Dr. Robinson, and I am the Blues Doctor. And this is my podcast, The Blues Doctor Recommends, and we're glad you're here. If you were here last week, you might remember that I had eye surgery just over a week ago, and I was channeling some famous musicians like Ray Charles or Stevie Wonder or Ronnie Millsap, and I was looking for suggestions for that. I actually asked the listeners for more suggestions, and I got a good one. Pyromedic 5008, who I know from some other sites, actually suggested Jeff Healey, who was a blind blues rock guitarist of some popularity in the 1980s and 90s. He had a couple of hits then. I'd kind of forgotten about Jeff Healey, so I'm glad you reminded me. So, thanks, Pyromedic 5008. Anyway, please remember to like and subscribe and share and ring the bell and make comments and all of those things, and we'll get on with it. Don't stop. I only have one entry on the calendar this week, but it's a good one. December 17th of 1770. Ludwig van Beethoven was born in Bonn, Germany. Beethoven was a musical revolutionary who went deaf in his 1920s, but he kept on composing even after that. Okay, let me just start from the beginning of that then. I only have one item on the calendar this week, but it's a good one. In December 17th, 1770, start over again. I only have one entry on the calendar this week, but it's a good one. On December 17th, 1770, Ludwig von Ludwig van Beethoven was born in Bonn, Germany. Beethoven was a musical revolutionary, went deaf in his early 20s, but he kept on composing even after that. He even wrote what might be his finest effort, the Ninth Symphony, after going deaf. He had kind of a messy personal life. He would toss leftover food over his shoulder when he was seated at the piano, and he was something of a hoarder, it seems like. He greatly he greatly admired Napoleon, at least at first. He based his third symphony, which was very dramatic and very bold, on the life and career of Napoleon. However, when Napoleon declared himself Emperor of France, Beethoven had a change of heart. He took Napoleon's name off the title, but otherwise left it pretty much as it was. Beethoven was born in the classical era of music and was influenced by the works of people like Mozart and Haydn and Schubert, among others. But he branched out widely from there as he got older. His later works became what became the romantic era of music and were considered groundbreaking, if not revolutionary. And to this day, his influence on music is immense. Ludwig von Beethoven died at age 56 in 1827. Don't stop. Had a hard time getting through that one. I guess so. The difference between a W and a V. Ludwig von Beethoven. There's two V's and one W. Okay. A few weeks ago, I did a segment on the top 10 myths and misconceptions regarding lung cancer, which was very popular. So we decided to expand that theme into an ongoing series. So starting now, we'll do about a monthly top 10 list on a different type of cancer and include that in our medicine segment. Ovarian cancer was an obvious choice for this because it's It's both insidious and potentially lethal at the same time. Plus it was my specialty back in the, plus it was one of the cancers that I specialized in while I was working. So without further ado, here are the top 10 myths and misconceptions regarding ovarian cancer. Number one, there's a screening test for ovarian cancer. That is incorrect. There's a blood test there is a blood test for a specific glycoprotein called CA125 that can be a marker for ovarian cancer, but it is not a screening test. There have been many attempts to develop a screening test or screening algorithm of some kind for ovarian cancer, but none of them have worked. The problem is that from a statistical point of view, CA125 has inadequate sensitivity and specificity to use as a screening test in the general female population. In other words, CA125 will not pick up all the cases. If you test, for example, a group of women with a known diagnosis of ovarian cancer, about 20% of them or so will not have an elevated CA125. That's what's known as sensitivity. The other way to look at it is to examine how accurate CA125 is. And unfortunately, for our purposes, there are many conditions that, besides cancer, that can cause CA125 to be elevated. Some of the common ones include endometriosis, infections, or benign cysts. In fact, a number of cases of elevated CA125 have no cause associated with them. That's specificity, or the likelihood that an abnormal test will actually indicate cancer. Another issue is that ovarian cancer is difficult to diagnose because it's not easy to access. In other words, to get to. The ovaries are deep inside the pelvic cavity, and the only way to do a biopsy or removal of the ovary requires a surgical procedure, including general anesthesia, which has significant risks of its own. So you add up the risks of the procedure needed to make the diagnosis and compare that to the relatively low sensitivity and specificity of CA125 as a screening test, you'll find that CA125 does more harm than good in that setting. Here's another way to look at it. If you screen 1,000 women who are asymptomatic with CA125, you might find 20% or 200 in whom it's elevated. However, ovarian cancer is a rare disease compared to breast cancer, lung cancer, prostate. So, of those 200 women with elevated CA125, only average maybe 2 will actually have ovarian cancer. And if you look at the 800 who screened negative, in other words, the 800 women who had a negative CA125, about 1 of them will actually go on to have ovarian cancer. And the significant complication rate of a surgical removal of an ovary is about 10%. And the death rate or mortality rate is about 1%. So, for every 2 cases of ovarian cancer found by CA125, one woman will die from one woman will die from a surgical complication, and you'll miss another woman with ovarian cancer altogether. So, CA125 does not work as a screening test and is not recommended for that. It is used to follow women who already have a diagnosis of ovarian cancer and have been treated typically with surgery and chemotherapy. In general, if a CA125 level rises in that population, it means the cancer is coming back. That's the appropriate use of CA125. Further, a corollary to that is that the pap smear can screen for ovarian cancer, and it is also incorrect. The pap smear screens for cervical cancer and does that very well, but it is not able to pick up ovarian cancer. Bottom line, there is no screening test for ovarian cancer. Number two, ovarian cancer is the silent killer, implying, in other words, that there are no symptoms, and that is incorrect. Ovarian cancer does usually have early symptoms like bloating or pelvic pain or feeling full sooner than normal or nausea or constipation or urgency, among others. The problem is that most women will have those symptoms more than once during their life, and yet very few women will actually get ovarian cancer. I used to go around and speak to groups of local doctors, typically primary care doctors and gynecologists in various cities and towns, about treatments for ovarian cancer. And full disclosure, I was paid by a drug company for that. Yes, I worked for evil big pharma as a side hustle for a while. I admit it. But back to the point, during these talks, typically they were held in a local country club with a cold chicken dinner, the typical rubber chicken. And I would show a list of the symptoms I had just mentioned, nausea and bloating and so forth. And I'd ask if anybody in the audience who has seen a woman with those symptoms in the last week to hold up their hands. Typically 15, 20 hands go up out of the 50 or so doctors who were there. And then I would ask them to hold their hands up if they'd seen a new case of ovarian cancer in the past year. No hands go up. And I use that little experiment to demonstrate the point that while ovarian cancer patients do usually have symptoms and are not silent, those symptoms are not useful because they occur in most women from time to time. Number three, you're only at risk if it runs in your family. Incorrect. There are families that have multiple cases of ovarian cancer, and they may have breast cancer associated with them. And we have identified several genes associated with an increased risk for ovarian cancer, but they represent less than 5% of all cases. In other words, the great majority of women with ovarian cancer have no family history. Number four, ovarian cysts mean you have cancer or a precancer. Again, incorrect. Benign ovarian cysts have virtually no risk of becoming a cancer. In fact, ovarian cysts are quite common. As many as 20% of women will have an ovarian cyst sometimes during their lifetime. And most women who have had, and most women who actually get ovarian cancer have had no history of ovarian cysts. Number five, a woman can lower her risk for ovarian cancer with lifestyle modifications. While there might be a grain of truth to that, it's generally false, largely because it's impractical. For example, having multiple children will reduce the risk of ovarian cancer, and taking oral contraceptives or birth control pills can lower a woman's risk. Those things are true, but they aren't meaningful. How many women take into account their risk for ovarian cancer when they're deciding whether or not to have a child? Same thing with contraception. If you need contraception, are you going to pick birth control pills because they can lower the risk of ovarian cancer? As I said, it's just impractical. The exception to this may be those women who have inherited a gene which increases their risk. As I mentioned before, there are studies suggesting that they may benefit from planned childbirth and or birth control pill use followed by a scheduled removal of the ovaries. But as I mentioned before, that only accounts for about 5% of cases. Number six, hysterectomy prevents ovarian cancer. Incorrect. The term hysterectomy means removal of the uterus. The ovaries can be removed or not at the same time as hysterectomy. and only ovarian removal and only ovarian removal refer, and only ovarian removal reduces that risk. Removal of the fallopian tubes, known as salpingectomy, can probably reduce the risk of ovarian cancer as well, but that data is relatively new, and the degree of effectiveness of removal of the fallopian tubes is not clear at this point. Number 7, only elderly women get ovarian cancer. Incorrect. While the mean age of ovarian cancer in the US is about 60, the range of ages is wide. This disease is occasionally even seen in teenage girls. In particular, women with a family history tend to get ovarian cancer at an earlier age. Number 8, ovarian cancer is incurable. Incorrect. Ovarian cancer can be treated effectively. The overall 5-year survival rate, which is the term most oncologists use rather than cure, is about 50%. But the more advanced the disease is, which we refer to by a staging system, the lower the 5-year survival rate is. Even with advanced disease, like stage 3 or 4, we may call it, the survival is not zero. It is not a death sentence. Overall, about 20% of women with advanced ovarian cancer will live for more than 5 years. Number 9, if your ovaries have been removed, you can't get ovarian cancer. Unfortunately, this is not completely correct. There are cases of women who have had their ovaries, uterus, and fallopian tubes removed, and they still get a disease that looks identical to ovarian cancer. We don't know exactly why, but perhaps the cells lining the abdominal cavity, sometimes called the peritoneal cavity, have the capacity somehow to become malignant also, and it mimics ovarian cancer in a sense. And number 10, genetic testing doesn't help. This is another time when there is a small grain of truth to this, but it's been misunderstood or misused. Historically, genetic testing may or may not have helped an individual patient with ovarian cancer who's feeling maybe, well, I've already got it. Why do I care what the genetic test shows? But the answer is that it helps her children, her siblings, and her other family members. If a woman tests negative for the primary genes associated with ovarian cancer, then there's no need to test her children. On the other hand, if the patient tests positive for an ovarian cancer gene, then her children have a 50% risk of carrying the gene also, and they need to know that. Further, there are some new drugs that appear to benefit women with the ovarian cancer gene, but not those without. The so-called PARP inhibitor class of drugs are associated with a higher response rate when given in combination with chemotherapy, but primarily, not exclusively, in women with hereditary ovarian cancer as compared to women without the ovarian cancer gene. So, there is now a potential direct benefit to genetic testing for women with ovarian cancer. Okay, you got all that, right? And I'm joking, but only a little. I've been asked all of those questions by patients and families over the years many times, so I hope this clears it up a little bit for you. Moving on, we had something come up very recently that I wanted to add to our medical segment today. Just this morning, Friday, December 19th, as we're recording, President Trump signed an order directing the loosening of federal regulations on marijuana. Specifically, Trump's order instructs the Attorney General to quickly move ahead with reclassifying marijuana from its current Class 1 to Class 3. Class 1 drugs are those with no medical use and are subject to misuse or abuse. This includes LSD, heroin, and some others. Class 3, in contrast, includes standard pain medications such as propofol, codeine, oxycodone, and others that are used all the time for medical care. The president mentioned this move to the press about a week ago, but we can now assume that the regulatory paperwork is being done currently to make it official. The DEA, or Drug Enforcement Agency, is actually charged with maintaining the drug schedule, and any change in that list will actually come from them. The DEA falls under the Department of Justice and Attorney General Pam Bondi, so they actually come under the executive branch and therefore are under the direct control of the president. So this action is perfectly legal. Congress has no direct role in the day-to-day actions of the DEA. So while they might voice an opinion, there's nothing they can do officially to alter it. So it is highly likely that rescheduling will happen. But it's uncertain how this but it's uncertain how this affect I wrote something weird here. Oh, I get it. Okay. But it's uncertain how this will affect the push to completely legalize cannabis. Currently, cannabis or its ingredients like THC and CBD are legal for medicinal use in 40 different states and for recreational use in 28. And that's in conflict with federal law right now. Decriminalization of marijuana is still opposed by some for various reasons. Some people oppose it for moral reasons, but really most of the vocal opposition has come from local law enforcement who have long used cannabis laws to keep their jails full and therefore keep receiving money from their jurisdictions, the cities or counties or states where they reside. Some rural sheriffs in Louisiana have admitted that marijuana crimes provide most of the revenue for their departments. They freely acknowledge and even advertise, in a sense, that they provide jobs to the community as jail officers and staff. There are parishes in Louisiana in which local jails or prisons are the largest employer in the parish. Marijuana laws have even been referred to as the new Jim Crow. It's clear that at least part of the reason that President Nixon started the war on drugs back in 1971 was to maintain, quote, control of blacks. Black Americans are incarcerated almost 4 times the rate of whites for marijuana related crimes, despite the fact that usage is about the same across the two groups. I've actually experienced this personally. For about 5 years, I served as medical director of Grace House, an inpatient nonprofit rehab facility for women with drug and alcohol problems here in New Orleans. During that time, some of the clinic staff and I began to notice that our clients at Grace House were almost 90% white, in contrast to the city of New Orleans, which it was about 60% black at the time. We were also aware that there was no difference in marijuana usage by race consistent with the rest of the United States. So, to find out why, some of our medical students from Tulane reviewed local court records and they noticed something. About 90% of white women with nonviolent marijuana offenses were offered the opportunity by a judge to go to Grace House instead of going to jail. As you might guess, almost all of them chose Grace House. In contrast, only about 25% of black women were given that option. As a result, Grace House was mostly white, despite the fact that it's in a majority black city. We published those results in 2021, but we haven't noticed any changes in those patterns to date. What do you think about marijuana laws? Are they appropriate? Are they ethical? Are they enforced fairly? Let me know in the comments and keep watching as President Trump's order goes into effect. I really think that most people believe the tide has turned on marijuana criminalization and that it's just a matter of time before it's completely legal everywhere in the United States. We'll see, I guess. And that's about all we have time for now. Anyway, as I usually say at this point, please watch next week's podcast. Okay? See you later.